It is now my pleasure to turn today's program over to Marcia Griffin. Ms. Griffin, the floor is yours.
Thank you all very much for joining us. As you were told, my name is Dr. Marcia Griffin. As a trained epidemiologist and context flow team member myself, it is my distinct pleasure to introduce this webinar and the context flow team supporting today's webinar. Dr. Joseph DiGiuseppe from Hartford Hospital, Dr. Jeff Jorgensen from MD Anderson, Drs. Franklin Fuda and Weena Chen from University of Texas, from UT Southwestern Dallas, Dr. Russell Hickens from UT San Antonio, Alan Stahl and Mary Beth Sharkey from BD Biosciences. Today we present an easy-to-digest and actionable webinar on 10-color panel design for B-cell screening. This work is the first in a series of webinars to be presented this year. It is the result of many meetings and hours of discussion. It is a concentrated effort by a group of pathologists, scientists, and laboratory technicians dedicated to advancing clinical research through the standardization of screening for hematopoietic and lymphoid neoplasias. I have to mention that this effort first began on the evening of January 10, 2012, when a group of friends, mainly pathologists representing private, public, and tertiary care hospitals, met over dinner to discuss standardization, current regulations, and the successes of the Euroflow's consortium strategic approaches. Since that time, this group of friends has evolved to encompass other members. Today, Dr. Joseph DiGiuseppe, Director of the Hematopathology and Special Hematology Laboratory at Hartford Hospital, will be presenting. He received his MD and PhD from Washington University in St. Louis and subsequently completed residency and fellowship training in anatomic and clinical pathology and hematologic pathology at Johns Hopkins. Dr. DiGiuseppe has dedicated his life to improving clinical research. He has directed the flow cytometry laboratory at Hartford Hospital since 1998 and is a past president of the International Clinical Cytometry Society. So thanks again for joining, and we hope you enjoy today's session.
Thank you, Marcia. I'm presenting obviously on behalf of the Context Flow group, and the Text Flow group actually has been working on standardizing tube development in clinical flow cytometry for a number of years now, and I'm sort of a late participant. But most recently, we've all been working with the BD FEX Canto 10-color system, and we thought it would be useful to put our thoughts together and try to optimize tubes that we could use clinically. And the webinar today focuses on the first of the tubes that we tried to develop, which is to screen for B-cell neoplasia. So the notion of standardization in clinical flow cytometry is relatively recent. I mean, traditionally, labs have developed their own antibody combinations, and so in everyone's lab, things looked a little bit different. The Euroflow group has done a tremendous effort, actually, to try to change that and standardize our work in clinical flow cytometry. And I'm showing here one of their seminal papers in which they describe a series of antibody combinations using standard protocols that were developed and validating them extensively. So the Euroflow group has designed and validated a so-called lymphoid screening tube, which is an 8-color 12-antibody assay that screens for abnormal B cells, T cells, and natural killer cells. And the general approach is illustrated in this slide. We can gate using CD45 versus side scatter or even light scatter on the lymphocytes. And then if, for example, in this top row, we look at the B cells, which are bright for CD20 and bright for CD19, they, of course, split into kappa and lambda bearing cells, some of which express CD5. If instead we gate on surface membrane CD3 bright events, those are the T cells, which are divisible into CD4 and CD8 positive subsets. We can even resolve a CD8 dim subset here that turn out to be gamma delta T cells. And then finally, the surface membrane CD3 negative, CD56 positive events are natural killer cells. They also express CD38 and variable CD8. The EuroFlow group has validated this tube with a large number of normal and abnormal cases, in particular using their dedicated software, which incorporates principal component analysis, and it identifies abnormal B, T, and NK cells in a preponderance of cases that have been studied. We talked about this approach, though, of using more than one antibody per channel, and as a group we were uncomfortable with doing that because it's quite common, of course, in lymphoid and hematopoietic neoplasia to see aberrant antigen expression, and that can be novel antigens that you don't expect on a given population. It could be loss of an antigen that you do expect. So if you can envision a T-cell lymphoma, for example, in which surface membrane CD3 has been lost, this algorithm would become difficult to interpret. So as a group, we sort of made an executive decision that we would try to design tubes in which we kept one antibody per channel just to avoid these kind of potential complications down the line. Next slide, please. Now, before the EuroFlow group came out with its tubes and protocols and so forth, there was a prior effort at standardization, and that was published in a series of articles in Clinical Cytometry in 2007, one of which is shown here. But the goal was a little bit different. The goal was to see what are the markers that are absolutely essential to try to identify and characterize hematopoietic neoplasia, and how should we be reporting these things and so forth. So in this particular work, for example, that's relevant to what we're about to develop, which is a B-cell tube, the optimal reagents for hematopoietic neoplasia were discussed by a group of international experts at this conference in Bethesda. Next slide, please. And shown here is the results of some of that consensus. In particular, we're going to focus on what did people think was important for evaluation of B-cell neoplasia. Well, in terms of the indications, the medical indications, cytopenias, lymphadenopathy, extranodal masses, splenomegaly, and so on and so forth, there was really tremendous consensus that 7 antigens really should be assessed in screening for B-cell neoplasia in any of these situations. And those 7 antigens were CD5, CD10, CD19, CD20, CD45, and kappa and lambda immunoglobulin light chains. Now around this time we had actually, in our lab, we had gotten brand new 8-color instruments, and we tried to develop panels in accord with the Bethesda conference recommendations. Next slide. And so about that time, we developed an 8-color screening tube for B-cell neoplasia that incorporated all of the recommendations of the Bethesda conference, as well as CD38, which can help you pick out plasma cells and B cells at different stages of maturation. And we've been using this tube now for 7 or 8 years. It's been very reliable. Here we're gating on CD19 positive B-cell events. This is a normal bone marrow. You can actually see the development going from weak CD45 to brighter CD45. Meanwhile, the earliest cells, which are bright for CD10 and negative for CD20, will lose some CD10 and start to acquire CD20. We have transitional B cells here, and ultimately the mature B cells. Notice that we go from blue to a combination of green and red, and that's because we've colored the kappa and lambda-bearing mature B cells either green or red. So as we progress from immature through transitional to mature, there's acquisition of polytypic immunoglobulin light chain. We're also able to resolve low-level CD5 and CD10 expression, which of course is helpful in phenotyping B cell neoplasms. So we sort of reviewed these data with the group, and this was felt to be a pretty good predicate tube, at least a starting point in our development of a 10-color B cell screening tube. Next slide, please. So now we have new instruments with 10-color capability, and that enables us to add at least 2 additional markers. And the question is, which 2? So we talked about this for a while, and a number of suggestions were made. Next. So the first was CD22. This is a pan B cell marker, much like CD19. Next. CD34 could be very useful in terms of screening for blasts. Next. CD200. In principle, you could potentially diagnose a CLL in one tube, although we didn't have CD23 in the tube. In addition, CD200 could be used. Some slight deviations in CD200 can be seen in follicular neoplasia. It could help you look for MRD, for example. Next. Another idea was to leave one or both of these extra channels empty and enable the user to personalize the tube and add drop-in reagents. Next. And the final consideration was to use a dump channel, and that is we're interested in B cells, we're not interested in T cells and monocytes and histiocytes, and perhaps we could clean up our B cell gate by removing anything that were positive for CD3 or the bright CD64 positive monocytes and histiocytes. So those were the considerations. Next. Now, one thing that sort of guided our developing this is we have a new challenge, and that is our principal gating antigen, CD19, has become a therapeutic target. Next. So we have 2 FDA-approved cellular therapies that are specifically directed against the CD19 antigen, the CAR-T, chimeric antigen receptor T cells. In particular, it's been approved for refractory resistant B lymphoblastic leukemia and more recently for relapsed large B-cell lymphomas. Next. Besides the cellular therapies, we have a bispecific T-cell engager antibody called blinatumomab, which also targets CD19 in conjunction with CD3, bringing the 2 cells in juxtaposition. And this has been approved for refractory resistant B lymphoblastic leukemia in adults. So our concern was in patients who had been treated in any of these ways, we might not be able to identify the B cells in question if CD19 were our pan B cell gating antigen. And so there was a consensus that we should incorporate, at the very least, we should incorporate CD22 in the tube to have a second pan B cell marker. Next. Okay, having decided that we need at least to add CD22, we need to understand our instrument in order to try to optimize an antibody combination. So the instruments that we're using are 10-color instruments. They are 3 laser instruments in which we have 4 fluorochromes detected off the violet laser, 3 off the violet laser, 4 off the blue laser, and 3 off the red laser. But not each of these fluorochromes is equally potent. Okay, next slide. So we need to understand in a little more detail the behavior of these fluorochromes in order to optimize our tube. And in broad outline, I've divided the fluorochromes here into bright, moderate, and dim. These are approximations, but they are based on data that BD has developed using these instruments and which they've published and presented at Horizon Tours and other venues. So we have some fluorochromes, and the prototype would be Brilliant Violet 421. And here, by the way, we are using conjugates to the same CD4 antibody. So we're comparing apples and apples, and the only thing that's changing is the fluorochrome to which the antibody is conjugated. So BV421 is an example of a bright fluorochrome. Here's the negative cells, here's the positive cells. We have many decades of resolution. Other bright fluorochromes include PE, PE size 7, and APC. So these are the fluorochromes you want to reserve for antigens that are expressed very weakly, or that it's very critical that you can resolve low-level expression. At the other end of the spectrum, some fluorochromes are relatively dim, and V500C would be one example of a dim fluorochrome. As you compared with the bright, we have, using CD4, again, the same antigen, we have quite a difference in our resolution. Now, many of the other fluors are in between bright and dim, and I've called them moderate here, and those, FITC would be prototypic of that. But others include BV510, probably BV480, BV605, PerCPSci 5.5, APCR 700, and APCH7. So this is one side of the coin. How strong is the fluor? How bright is the epitope that you're trying to detect? But it's only one side of the coin. Next slide. The other side of the coin is spillover and spread. Each fluorochrome, of course, has an emission spectrum, and depending on the mirrors and the filters that you're using, some of the signal from the primary channel will show up in secondary detectors, and that contributes to the background in those detectors, impeding your resolution. So again, BD has been very helpful in putting these data together so that we can understand how the instrument performs using each of the fluorochromes that we could potentially use. Let's take the example of BV421, one of our bright fluorochromes. On the x-axis, we have CD4 expression. Okay, so we have negative and positive cells. Now on the y-axis, we're looking at there has not been any addition of a conjugated antibody in any of these other colors. So any signal that we see is actually coming from the BV421. So let's take the example of BV510. It turns out that on the y-axis, there's really not much variation in the y-axis of the strongly positive CD4 cells compared with the negative cells. And that holds true for all the other fluors pretty much for BV421. So the positive and the negatives, they look similar in the y-axis. So we are not having much spillover and the consequent spread in those other channels. Next slide. So that's not true for every fluorochrome, however. PerCPSci 5.5, for example, if we look at the PerCPSci 5.5 positive CD4 cells, notice the shape of the population is oblong here. It is spreading in the Y channel. And that is because we have spillover coming from PerCPSci 5.5. The net result is that if you were trying to measure an antigen in PE-Cy7 on a CD4 positive cell, your resolution at low levels would be impaired. And so you really could only detect a relatively bright signal on the CD4 positive cells as opposed to the CD4 negative cells where your resolution would be better. So this is referred to as spread, and it impedes your sensitivity. And it's the other side of the coin we need to consider besides fluorochrome strength. Now, in the case of Per-CP Psi 5.5, we have to, there is spread in PE Psi 7. There is also substantial spread in APC R700, to a much lesser extent in APC and APC H7. Next slide. Here's another fluorochrome excited by the red laser, APC. And in this case, we have two principal issues with spread in APC R700 and APC H7. Whereas the other channels, we don't have much of an issue for spread. Next slide, please. So again, BD has nicely summarized these data, which is very helpful when you're trying to design a tube. And it talks about both the fluorochrome strength and the effect of spillover on your stain index. So if we look along the diagonal here in black, this is the so-called single positive staining index, and this relates to fluorochrome strength. So we said, for example, that PE Psi 7, APC, and BV421 were in our bright category, and so they have very high stain index. In contrast, V500 we said was a dim fluor, and that has a relatively low stain index. But remember too that we are also affected by the spillover and the consequent spread in the other channels. So, for example, in the case of Per-CP Psi 5.5, we had substantial spread in PE Psi 7 and APC R700, and so that results in a loss of resolution for cells that are double positive. So if they were positive for both whatever you have in Per-CP Psi 5.5 and what you're trying to measure in PE Psi 7 or APC R700. So the red signifies here a loss of greater than 80% of your single positive stain index. And so these red areas are the particular areas that we need to be mindful of when we design our tube. In the case of APC, we need to be cautious about spillover into APC R700 and H7. APC R700 can spill into APC H7, and PE even spreads in Per-CP Psi 5.5. So these are some areas that we will consider as we design the tube. Next slide, please. All right. So this is to remind us that panel design is an iterative process. We went through many versions of our B-cell screening tube. It seemed simple at the time. We even had an 8-color head start, and we were trying to add 1 or 2 more colors, and it turned out to be not trivial. In fact, we went through at least 10 versions. I have to thank Dr. Jorgensen for keeping track of these. But again, here is our predicate tube, the 8-color tube, and then these are various versions that we've tried over the course of the last 1.5 to 2 years. And I'm not going to walk you through every single version that we went through, but we will hit the high points and see where we hit some stumbling blocks and then adjusted. Next slide. Next, please. Next, please. Yeah, thank you. Okay, so we had consensus that CD22 needed to be in the tube, as we've talked about earlier. And we have 2 unoccupied channels relative to our 8-color predicate tube. So APC R700 is a novel fluorochrome that we now have available to us, and BV605, neither of which we could do in our 8-color configuration. APC R700 was actually a very attractive place to put CD22. And the reason is shown here in the lower panel. Remember our spillover spread issue. Per-C Psi 5.5, where CD20 is currently in the predicate tube, does spill into both PE-Psi7 and APCR 700, and you can see that effect here. However, one way to get around that is to put antigens in these colors, which would be expected to be positive on CD20 bright cells. So for example, CD19 is already positive on CD20 strongly positive B cells. So that we get away with that even in the 8-color world. And CD22 would also be predicted to be positive on any mature CD20 positive B cells. So from a spread issue, CD22 this would be a great, APCR 700 would be a great place for CD22. The only question is it a bright enough fluor? It's not among the strong, it's in that category that we called moderate, but we were hopeful that it would be bright enough, and then we would sort of cover our spread issues here. Next slide. So BD made a CD22 APCR 700 conjugate for us so that we could test this hypothesis, and the results are shown here. Here we have CD19 and PE-Psi7. You can see it's a very robust gating antigen. It detects both the immature in blue and the mature B cells in green and red. CD22 picked out most of the B cells, but unfortunately the less mature B cells would blend into background. And if we relied on this as a gating reagent, we might miss a subset of the B cells. Here the same data are displayed in a different way versus CD45. The immature B cells have the weakest CD19, and it increases with maturation. CD22 is a little more complicated in development. It starts out sort of moderate, and then it drops down, and then it goes back up with maturation. So we were particularly missing these early B cells with extremely weak CD22. So as much as we liked APCR 700 as a location for CD22, our concern was that the fluor was just not bright enough for this particular application. Next slide. Okay, so much of our efforts were trying to rebuild the tube, putting CD22 in different places. And many months of work are kind of summarized here. Of the four, it seemed that, of these four that I've shown here, it seems that the PE conjugate of CD22 is probably our gold standard. We have very low background. We have nice resolution of mature and immature B cells, and even those B cells with the weakest CD22 are resolvable from background. In Per-C Psi 5.5, which is more of a moderate rather than a bright fluorochrome, we did get some loss of resolution here at the low end. PE-Psi7 is a bright fluorochrome, but for whatever reason, our background was extremely high with this particular conjugate. So even though on paper you might have something that looks like it should work, it's important to test that individual antibody and make sure that there's nothing idiosyncratic that could affect your results. BV480 goes where it's detected in the V500 or BV510 channel and is actually a little bit brighter than both of those fluorochromes. And so BD did make a BV480 conjugate for us, and in fact the results are quite good. We can resolve the mature and the immature B cells. But it turns out in this part of the spectrum, there is some background that below which we can't really go. And so it does kind of impair our resolution relative to PE. And ultimately, we felt that our best choice for CD22 would be PE. Next slide. Now, back to our iterative design. You'll notice that we went through many, many iterations, and nothing changed in FITC and PE. And that's because the changes were happening at this end of the tube, where we were trying to find a home for CD22. In the beginning, we were looking at APCR 700, and we looked at PERSI PSI 5.5, we looked at PE Psi 7, we looked at BV 480. But as you can see, ultimately we decided CD22 was the best place. But that means that we're going to have to displace a light chain, which is kind of a big deal for us because the light chains obviously are very important in looking for B-cell clonality. Next slide, please. So, do we really want to move immunoglobulin light chains? Kappa, FITC, lambda, PE is utterly traditional, and frankly, going back to the days of two-color flow cytometry, people have been using this combination. We know it works. We have years and years of experience. But is it really optimal if you think about it? So the expression level of kappa and lambda antigens is comparable, but PE is a much brighter fluor than FITC. So in a sense, we're not making best use of PE since FITC is bright enough for immunoglobulin light chains. So to make room for PE in CD22 and PE, could we move one of the light chains to a fluorochrome whose brightness is more comparable with FITC? It turns out that mouse monoclonal anti-human kappa and lambda had already been available in BV605 conjugates, and fortuitously BV605 is extremely comparable to FITC in brightness. So this gave us an idea that perhaps we could put CD22 in PE and then move one of the light chains into BV605. Next slide. Now, from a brightness standpoint, that makes sense. Does it make sense from a spillover standpoint? Well, in the case of FITC, there is a little bit of spread in PE, but remember we're going to have CD22 in PE, so that will already be positive, so that's not really an issue. And in the case of BV605, we don't really have any, these are relatively minor spillover. In the case of CD22 and PE, it is possible that super bright CD22 positive cells could cause a little bit of spread in our BV605, but nothing in the red zone here that should be a problem with our proposal. Next slide. So, the mouse monoclonal antibodies were available off the shelf in BV605, but are they the best light chain reagents? So remember, we did have a predicate tube, which used polyclonal antibodies, and so we certainly we wanted to make sure that these results would be at least as good as the predicate tube. And in the case of the mouse monoclonals, comparing apples to apples here, everything is conjugated in FITC, we felt that the mouse monoclonals were just a little bit dimmer than these polyclonal antibodies. But in addition, there's goat polyclonal antibodies that are available. They had not yet been conjugated in BV605, but when we compare them in FITC, the goat polyclonals are at least as bright, and frankly probably a little brighter than the predicate polyclonal antibodies. So we asked BD if they would conjugate goat polyclonal antibodies in BV605 for us. Next slide. And here we put all 9 antibodies together just to see if it would work. And actually, here's our CD22. Very nice resolution at the low end. Everything looks reasonable. Here's some plasma cells, CD38 bright. Here's our kappa and BV605 lambda FITC. So no obvious problems here. Next slide. Now showing the same data, but gated on B cells, and with the exception of this top left dot plot where we are showing all viable cells, and you can see kappa versus lambda. Everything else is gated on B cells. So we have our light chain negative immature B cells, polytypic expression. We can track the development of the B cells acquiring CD20 and then becoming transitional B cells with CD5, ultimately losing their CD5. We're starting out here with bright CD10 and no CD20, losing a little bit of CD10, acquiring CD20, and dropping down. Moreover, we can compare CD5 positive and negative, CD10 positive and negative with respect to light chain expression, and everywhere, no matter how we parse these B cells with the other antibodies, we're still getting a nice polytypic distribution. So it should be, in principle, very easy to find small clones that express any of these other antigens at different levels. Next slide, please. Okay, so we have CD22 in the tube, and it seems to be working. We still have a channel left, and that's the APCR700 channel. So this actually becomes what's referred to as a fluorescence -1 or FMO control. And these are actually very useful if you're trying to see what is the background in the channel that I'm about to add an antibody to. And so, not surprisingly from the earlier discussion, because of the spillover both from CD20 in per-CP-Sci 5.5 as well as the APC, we do have some background here in APCR700. So again, we had entertained a number of other options, including having a dump channel here to eliminate T and T cells and monocytes and histiocytes. But alternatively, we could leave this empty for a drop-in. The only caveat would be that one has to be aware that there is some background in this drop-in channel. So you'd want to use an antigen that is going to be very bright and easily resolved from this background. Next. And then again, please. Thank you. Okay. So we're getting to, oops, if you could go back one, please. All right. We're getting to the bottom of our list here of our iterations, and we've got CD22 and PE. We've moved the light chain to BV605. In the penultimate version of the tube, we were using this as a dump channel with CD3 and CD64. Ultimately, we decided it really wasn't particularly helpful. We've already got a lot of gating reagents in the tube now, CD19, CD22. And so, frankly, without relying on a dump channel, we can get a very clean signal focusing just on B cells. And ultimately, we felt it would be better to leave that channel empty, and if someone had an application for which they could use it, that would leave the tube a little more flexible. But we felt that the backbone that we had was pretty solid. Now, we did make one last tweak at the last moment, and that was a swap of CD5 and CD10. Now, APC and BV421 are both in the bright category. So in principle, this should be an even swap. But in our predicate tube, we had been using this for a number of years, and there were cases in which low-level CD10 expression, for example, in follicular lymphoma, was very difficult to resolve from background. And so we wondered whether moving CD10 into BV421 would help our resolution at the low end in terms of CD10. Next slide. So that's the final modification that we made. Instead of having CD5 in BV421 and CD10 in APC, we have CD5 in APC and CD10 in BV421. Next. And one more, please. Thank you. Okay, perfect. Oh, if we could go back, please. Perfect. So this is the area I want to draw your attention to. This is normal bone marrow. Here are the B cells maturing. And these are the mature B cells. Now with CD10 and APC, there's a little bit of variability here at the low end such that it's not so clear where the transitional B cells end and the mature B cells begin. And so if you had a follicular lymphoma that were weakly CD10 positive, you might not be sure whether those were just normal B cells. It looks like with CD10 and BV421, however, we get a much tighter cluster here, and it seems easier to resolve low-level CD10 expression from negative. Now, the question is, did that hurt us on the CD5? It looks like we've improved the CD10 slightly, but have we taken a step backward on CD5? If we compare CD5 and BV421 versus APC, however, they're essentially indistinguishable. So ultimately, we thought that the version 10A was better than version 10, and this was kind of our final version. So having gotten to this point, we then wanted to try the combination on a number of abnormal cases. Next slide, please. So here's a case of chronic lymphocytic leukemia, and in each of these cases, as an internal control, I've highlighted the normal B cells in green and red, or kappa and lambda bearing cells respectively. So here we have a few normal B cells, but there's a predominant population here in blue, which is weak for CD20, weak for CD5. Notice they're also weak for CD22 relative to the normal B cells, and they have dim monotypic lambda light chain in comparison with the normal B cells whose lambda is brighter. Here we see 20 and 22 are both weaker compared with the normal. CD10 is clearly negative. So that switch to BV421 helps us here because we might have had a little bit noisier signal at the low end and equivocated on whether there might be some weak CD10. So that seems to be an improvement. And again, weak monotypic lambda light chain expression. Next case. Okay, here's the tube on a case of B lymphoblastic leukemia. Again, the mature B cells highlighted in green and red, brightly positive for CD20 and CD22. In contrast, the blasts are predominantly negative for CD20 with some weak expression in a minor subset. CD22 is also weaker. CD10, brightly positive, abnormally bright, in fact, brighter than what we would see in normal B cell precursors. We have weak CD45 as expected. Again, here's the weak CD22. Here we have nice co-expression of CALA along with CD19 and CD38. So in a precursor, lymphoid neoplasm, the tube also seems to be effective. Next slide, please. This was an interesting case I wanted to show, in which there were actually two phenotypically distinct monoclonal B cell populations in the patient's sample. Again, let's start with our normal controls, kappa and lambda in green and red. And we have two abnormal populations in blue and orange. The blue population sort of resembles CLL in that CD22 is weak, CD5 is positive, CD20 is weak, CD10 is completely negative, light chain is dim and monotypic, in this case lambda. But then we have a second clone that is distinct. It has bright CD22, bright CD20. It's also negative for CD10. And it's monotypic, but for kappa, not lambda, though it is dim, like the CLL clone. So here we've resolved, with our 9-color tube, we've actually resolved not only the normal B cells, but 2 different clonal B cell populations. And it was quite easy to do, having all these various reagents at our disposal in the same tube. Next slide. Now, we went through a lot of trouble to find a home for CD22. And I think this last case illustrates why that's so important. This is a patient who had B lymphoblastic leukemia and relapsed, and was then treated with blinatumomab, which is a bispecific T-cell engager that does target CD19. Now, traditionally, we would try to find the B lymphoblast by gating on CD19. This is our pan B cell marker. And in this case, there are a few which are highlighted because they're so rare. They're CD19 positive, CD22 positive, CD10 positive, and they have slightly dim CD45 and increased side scatter. But that's not the whole story. If instead we gate on our B cells using CD22, we have an additional 98, 97% of the actual tumor burden, which is CD22 positive, but negative or only extremely weakly positive for CD19. Notice that they reside in exactly the same place in CD45 side scatter. They have the same CD22 intensity. They also have CALA. So in blue, these are also lymphoblasts, which we would not have detected or potentially have missed if we relied solely on a CD19 gate in patients that have been treated with CD19 therapy, illustrating the utility of including another pan B cell marker in the tube. So I believe that's the last case. And thank you for your attention.
At this time, our panel of experts would like to take any questions you may have for us today. To ask a question via the web, click the Q&A button in the lower left-hand corner of your screen. Type your question in the open area and click Submit.
All right, so we have our first question coming in. And the question is from Camille. Have you tried Kappa BV605 for intracellular staining?
We have not. It's a great question, and I think we need to do it. But as of now, we've not tested it intracellularly.
Okay, thank you. Our next question is from Dr. Dorfman. Did you consider adding CD23 and CD11C to the tube?
We didn't. Our goal here was really to make more of a global screening tube, and so neither one of those was really entertained as sort of a first-tier antibody.
Okay.
Sorry, can I add, we did try hard to put CD200 in, but that was very challenging because we need a very clean background, and we just couldn't achieve it with the various spillovers, as well as a bright stain. So that was, we couldn't get that in.
Yeah. Thank you. So there's another question coming in. Many groups, including Euroflow, are taking what is termed a sentinel approach to screening. This approach stacks markers on separate cell populations and reduces the number of tubes. Did ContextFlow consider adopting the same approach? And we'll start with you, Dr. Jorgensen.
Sure, yeah, we did look at that as Dr. DiGiuseppe addressed early in his talk. We just felt, given the, number one, the diversity of possible neoplastic populations, that if you have anything atypical, it can be very confusing to interpret. And then the other issue is, again, given the anti-CD19 therapies, we lose some of those background markers, and all of a sudden you don't know if you're looking at B cells or T cells. So we felt the best was to stack in extra B cell markers but keep the T cells and B cells quite cleanly separated.
Would anyone else from the panel like to add to Dr. Jorgensen's answer?
No.
Okay. So we have a question, another question. How did you QC these markers? So I don't know. Joe, do you want to take that one?
I'm not sure what is being asked.
Like from maybe an FMO perspective, or we'll skip it. We'll see. Neha, if you could clarify your question on what you mean by the quality control side, we'll come back to it.
Do they mean control of specificity or control of functionality?
Yeah. Let's answer it from both sides. Let's answer control of specificity first and then functionality next.
Well, frankly, many of these reagents we've been using for years, and we have a lot of familiarity with them and experience. And knowing the patterns of normal antigen expression in normal is really the best way, I think, to verify that you're getting appropriate staining, positive and negative. You want to see lack of staining in populations that should not be expressing the antigen and vice versa.
And I'll say that most of these antibodies, if not all, I can't speak to each one specifically, but they've gone through the whole process as part of the CD nomenclature workshop, and were identified as binding to these molecules via that workshop.
Okay, great. Thank you, Alan and Joe. So we have another question from Arun. He says, hi, we faced a lot of difficulty in kappa lambda tube with nonspecific and background staining. Do you recommend any particular method in sample prep for the kappa lambda tube? And I think this is a great question, and if I could ask Joe to answer it first, and then Jeff, if you would follow up with what you do in your lab.
Sure. So in our lab, the way we do it is we actually pre-incubate the cells at 37 to permit endocytosis of any bound immunoglobulin, which lowers the background tremendously when you then come back and add your labeled anti-kappa and lambda.
Okay.
And there are lots of ways to skin the cat. We generally have good luck doing a pre-lysis. So we do our red cell lysis and then 2 washes, and then do our surface staining.
Okay. And Dr. Chen or Dr. Fuda, would you guys like to add anything?
Sure. Yeah. One of the things that we do is, we're triaging our cases up front. So in situations where you may see a lot of background type staining for surface immunoglobulin, we will go ahead and pre-incubate at 37 degrees. If the patient has HIV or some type of rheumatologic disorder, we do that in cases that are follow-up cases where the lymphomas were negative for surface immunoglobulin. So we'll pre-incubate in those situations as well. Or if we have low cellularity to the sample, so that we wouldn't be able to do it again if it came back with high background staining for kappa and lambda. Otherwise, we don't do the pre-incubation, and if we do have difficulty with background staining, then we will repeat the tube by incubating at 37 degrees.
And do you guys do you add fetal calf serum, any kind of blocker, or just in the blood or marrow?
No.
Okay.
All right, so we do have 2 more questions, and then we'll be wrapping it up with a plug to answer Dr. Dorfman's second question. So the first of the 2 questions is from Dr. Gregg, and he asks, since this tube offers a lot of options for gating, and he references CD19, CD20, and 22, was there any thought about dropping CD45 and adding something more useful like the CD200 that you mentioned earlier, Dr. Jorgensen, or the 2311C? His comment is, yes, immature B cells may be more challenging to isolate, but mature cell neoplasm neoplasms should be much. Who wants to take that first?
Yeah, so Bruce, the short answer is that we didn't really entertain that, and I mean, from the simplest way to think about it is that 45 was recommended in the Bethesda conference, and we didn't want to omit something that had already been in use and approved. And it was in the predicate tube. Having said that, I think your suggestion is a very interesting one. Even though we didn't really think about it or pursue it, it's a very interesting idea, and it could certainly be tried.
Yeah, I guess I'd add that, of course, one of the Bethesda recommendations was include some very broad screen for unexpected diagnoses. So, we have lymphoma patients that come to us and they've got secondary MDS or AML, and I'd be kind of loathed on a new patient to not have CD45 somewhere in your analysis.
Okay, thank you. So we have Ahmad asking, did you use cells or beads to establish target channels and your compensation?
So for target channels, we use beads from BD, actually. For compensation, however, we do use cells. Particularly in some of the violet floors, we get better compensation results using cells rather than beads.
Okay, so we have one more question, and that is, why did you not just adopt Euroflow?
Well, I think Jeff had addressed this in terms of the sentinel approach. I think we were uncomfortable having multiple antibodies in the same channel because phenotypic aberrancies, either gain of antigen that we don't expect or vice versa, could potentially throw your entire gating strategy off and mislead you. So we weren't comfortable with that approach as a group.
Okay. Is there anything else anyone else would like to add?
And also right now it's very important to add a CD22 because more and more this kind of immune modulating agent to use in the clinical setting. So adding CD22 is a great plus for this B-cell tube.
Thank you, Dr. Chen. All right, so Dr. Dorfman, I'm going to take this question to you, Jeff. He asks, what does your 10-color T-cell tube look like?
It's not quite ready for prime time, but we're getting close. In February, we expect to be presenting it.
Yep. So stay tuned for a webinar in February to see that. And also, everyone who's on the phone, be watching for our next announcement. We'll be doing monthly webinars, and the one next month is on HLA in using both the new Faxlyric and the Faxvia. So thanks again to everyone for your time today. Thanks very much to the panel for all your efforts in getting this off the ground, and we look forward to seeing everyone next time. Have a good day.
Thank you.
Thanks, guys.
Thanks, guys. Bye-bye.
Bye.
Thank you to all our participants for joining us today. We hope you found this webcast presentation informative. This concludes our webcast. You may now disconnect. Have a great day.